Periapical radiolucency. During my practice, I saw many similar looking lesions on the radiograph, making diagnosis tricky. After years of clinical experience, I can now differentiate between these lesions. Here, I have 5 radiographs of different patients that show similar periapical pathologies. Knowing each condition's clinical and radiographic characteristic features helped me in my diagnosis. In today's video, I will discuss the differential diagnosis of periapical radiolucencies through these 5 cases. Periapical radiolucencies can be divided into 2 categories: true and false. True ones are those in contact with the tooth and do not shift in their position when there is a change in the angulation. False periapical radiolucencies not in contact with the tooth shift in their position with a different angulation. Let us begin with the first radiograph. What abnormal features do you see? Yes, a root stump of 4-6 and a well-defined unilocular radiolucency lined with a sclerotic border in the region of 4-5, 4-6, 4-7. An additional occlusal radiograph revealed a buccal expansion of cortical bone in the region. We cannot come to a probable diagnosis knowing only the radiographic features. Let me explain the clinical history of this case. This patient had a swelling on the lower right side of the face of around 4 by 3 cm, extending inferiorly till the lower border of the mandible. The swelling had gradually progressed to the size in 1 month and was not painful. On extraoral palpation, the swelling was soft, smooth, non-indurated, and non-tender with no pus discharge. Intraorally, the swelling was reddish pink and obliterated the vestibule on the right mandibular posterior region in relation to the 4-5, 4-6, and 4-7 regions, with no lingual bone expansion. On intraoral palpation, I felt a smooth, clear border with soft consistency. Fine needle aspiration cytology produced a pale yellow liquid, which led to the belief that it could be a radicular cyst. Histopathological evaluation confirmed my diagnosis. Now let us consider the second case. What do you observe here? Caries involving pulp. Radiolucent lesion. Yes, this radiograph shows a well-defined round to oval radiolucency of 1:1 centimeter in relation to the mesial root of 4-6, most likely due to the pulp involvement. Based on the size, I decided it was a periapical granuloma. Let us correlate this with the clinical findings. This patient came with pain in his lower right back tooth. After the first episode of pain that subsided with medicines 2 years ago, he experienced it again a couple of times and then was pain-free for a long time. As seen in the radiograph on intraoral examination, 4-6 had deep caries and it was tender on percussion too. An interesting fact to note is that this lesion typically involves non-vital teeth and is painless. In addition to this, a granuloma like a periapical cyst has a sclerotic border. Both the above were absent in this case, and so I could conclude that this was a case of an infected periapical granuloma. Before we move to the next radiograph, let us briefly look at the key points of the first 2 diagnoses. Feel free to take a screenshot. Moving on to the third radiograph. Here is a well-defined round radiolucency with a smooth border less than 1 centimeter in size and in the periapical region of 2-2. The root appears resected and the tooth is root canal treated. Interestingly, I found this pathology by sheer coincidence. The radiograph was meant to rule out a periapical change in a patient who came with a decayed 2-1. Instead, it led me to the pathology on the periapical region on 2-2. The patient revealed that he had undergone a minor surgical procedure called episectomy along with endodontic treatment for 2-2. I concluded that the radiolucent lesion was a surgical defect. Now, think about this. How did I differentiate a surgical defect from a periapical granuloma or periapical cyst? I mean, they do look similar, don't they? The answer lies in the history of treatment procedures done, clearly evident in the radiograph. Moving on to the fourth radiograph. What do you see, and what could be the diagnosis? There are two well-defined radiolucencies seen in the periapical region of 3-1 and 3-2, less than 1 centimeter in size. The first thing that comes to my mind is a periapical granuloma based on its size and appearance. But is there a decay in the teeth that could lead to this particular lesion? No. Is there a history of trauma? According to the patient, no. On examination, tenderness around the teeth as well as the surrounding area was absent. This helped me rule out periapical granuloma and led me to diagnose it as early stage periapical cemental dysplasia. Once again, let us look at the key comparisons before we move on to the fifth radiograph. Feel free to take a screenshot. Moving on to the fifth radiograph. Notice the well-defined cyst-like radiolucency in relation to the roots of 3-6, 3-7, and 3-8, extending superiorly between the premolar and molar roots, producing a scalloped appearance. Could this be a periapical cyst? Caries without pulp involvement are evident in 3-6, with an intact lamina dura in 3-6, 3-7, and 3-8, thereby helping me rule out periapical cyst. The large size of the radiolucency helped me rule out periapical granuloma and periapical cemental dysplasia. There is no evidence of any surgery done in the region to suspect a surgical scar. So I diagnosed this lesion as a traumatic bone cyst or a simple bone cyst and confirmed it with a histopathological evaluation.
Pop quiz.
With this, we come to the end of this video. Now, other than the cases I have discussed here, there are a few other lesions to be considered in the differential diagnosis of periapical radiolucencies, such as osteomyelitis and periodontal disease. There are also other conditions that this video may not have covered. However, this tabular column will help you understand better. Feel free to take a screenshot. We hope you had fun learning with us.